Okay, good afternoon, everyone. My name is Maura Canavan, and I am with the Community Health and Wellness Department at Suburban Hospital. I'm so excited that today we are joined by Dr. Michele Bellantoni to discuss osteoporosis and bone health as we age. We'll have time for questions at the end, so please feel free to send them in the Q&A box if they come up throughout the presentation. And you'll also receive a link to the evaluation at the end of the presentation. And we'd be grateful for you to fill that out so we can continue to improve our programs. So thank you so much, and I will now pass it on to Dr. Bellantoni.
Well, thank you very much, and good afternoon. I'm delighted to share with you my recommendations for successful aging with respect to bone health and management of low bone mass as we age. I'm going to share my screen so that you can see my PowerPoint slides, and let me go to slideshow here, and we'll begin from the beginning. So let me go to the next slide. So my goal for this talk is that you will understand age-related changes in bone health that contribute to fractures. And at the end of the day, our goal with bone health and aging is to prevent fractures. Fractures result in immobility, pain, debility. So our goal here is not fancy x-rays or bone mass, bone densities, but in fact, to age successfully without breaking bones. And then I hope that we'll show you how to reduce these risks of age-related fractures through an approach of healthy behaviors, nutrition in particular, physical activity, and then appropriate use of our screening test bone density, and appropriate use of FDA-approved medications. So let's start with just a basic physiology discussion. Bone is not stagnant. Bone is an active body organ with metabolism, and this metabolism has some age-related changes. There in the top there on the left shows that the bone has these certain types of cells that have duties. Osteoclasts are cells that basically chew up bone for repair purposes. And then osteoblasts are the cells that lay down new proteins. We call them matrix proteins. And then calcium, a mineral, calcium, is deposited on these proteins in a really interesting architectural pattern that makes bone strong. So proteins in bone are not strong. They're flexible, but not strong. Calcified proteins are what give us the architecture of bone and our bone strength. But our bone is the repository of the mineral calcium in our body. And calcium plays a role in many other types of body physiology metabolism. For example, muscle contraction and cardiac, our heart beats with calcium, and our muscles contract with calcium. So our bones serve a very important role, and that's keeping calcium available. And our body has multiple hormones that regulate the blood level of calcium. I have many folks who say to me, oh, I'm great. I'm taking enough calcium in my diet because my blood level of calcium is normal. And I will tell you that is not the right way to understand physiology. The body goes to great lengths to keep that blood level of calcium normal, unfortunately, at the expense of our bone. So if we don't take in enough calcium and calcium levels very minimally fall in the blood, hormones, and particularly parathyroid hormone, 4 glands that sit around the thyroid gland, make this hormone that causes those osteoclasts up there to rev up and chew up bone to release calcium into the blood. Yes, blood levels of calcium can become abnormal when there are medical conditions or medications, but that is an abnormal physiology that can lead to bone loss. So normal aging and normal blood levels of calcium are what we expect even in severe osteoporosis. And so we have to, I'll talk about nutrition and bone health shortly. But my point is with aging now, for women, as estrogen levels fall with menopause, these osteoclasts begin to rev up and have an accelerated loss of bone. And that's in the larger box here. And you see at the bottom there, this increased bone resorption with menopausal transition. And but without an increase in new bone being made. And the net effect, unfortunately, is thinner bone. And bone is not solid. It is actually, there are different types of architecture in bone, our spine bone, and in our long bone of the leg, the femur bone that goes into the pelvis, the part of the femur that goes into the pelvis called the femoral neck is very much more of like a Swiss cheese approach or to bone with these, what we call spicules or little radiations that are interlocking that give that bone its strength. But as a result, a lot of surface area that can be lost when there are these hormonal changes. So spine bone and femoral neck bone can be lost quickly in the menopausal transition that actually can extend out 10 years and can have as much as a third of bone mass for women lost during that 10 years of menopausal transition. So that's a pretty significant amount of bone loss. Men do not have this abrupt change in hormonal reproductive hormones, but there are age-related changes in testosterone lowering that can have a slower impact on bone, but much less of a bone resorption with aging. But there is a slowing of new bone being made with both men and female, male and female aging that can result in lower bone mass. So peak bone mass for men and women is about age 30. So very important for our younger adults to have good bone health behaviors of nutrition, physical activity, so that they can achieve a peak bone mass that's optimal. Because from there, we really have very minimal medications to improve the amount of bone one has. And really our major medications are preventing further loss with aging. But there are medical conditions that impact our bone health we have to be aware of. The most significant ones I've listed in this slide. So I group them into types of conditions. So autoimmune or rheumatologic conditions. I want to make a point, though, that our garden variety arthritis with aging, osteoarthritis, the wear and tear on the joints, that is not associated with thinning of the bone itself and fractures and osteoporosis. However, more of the immune types of arthritis, inflammatory arthritis, like rheumatoid and psoriatic arthritis, psoriasis associated with arthritis, systemic lupus, and another type of autoimmune condition called systemic sclerosis. All of those inflammatory conditions have an impact on new bone being made, less new bone being made. And even without the use of the medications, the steroid medications, there can be a lower bone mass associated with these conditions. Other inflammatory conditions, Graves' disease or active thyroid inflammation is associated with rapid bone loss. That's osteoclasts revved up and bone loss. The good news is Graves often happens in younger women, and if it's treated quickly, those younger women before peak bone mass can actually recover some of the bone they lost during the active Graves' disease. However, older women who develop inflammatory arthritis, they often can't recover bone that's lost during the time of inflammatory disease that's impacting their bone metabolism. So as we treat these autoimmune and rheumatologic conditions, we want to think about bone health and how we get those inflammatory conditions under control quickly to prevent bone loss associated with these medical conditions. How about GI conditions? Inflammatory small bowel disease, typically called Crohn's disease. Very significant impact on bone health nutrition. So vitamin D and calcium absorption through the small bowel impacted when there's active Crohn's can lead to thinning of the bone. Celiac disease is an allergy to wheat or gluten in wheat that causes inflammation in the small bowel and malabsorption of our bone nutrients, vitamin D, calcium. as well as vitamin B12 and iron, are two other nutrients that are impacted by Crohn's and celiac disease in particular. And then gastric bypass surgeries for weight reduction, bariatric surgeries impair nutrition. And patients who undergo these surgeries need a very aggressive approach with nutrition support to protect their bone. Significant weight loss, anorexia nervosa in young adults, particularly young adult women, has an impact on bone health that can be very devastating. Women not achieving adequate peak bone mass, having active bone loss if that condition continues into the 30s and 40s. And major depression, the hormones associated with depression also cause osteoporosis. Amenorrhea for women is a significant cause of low bone mass when it's occurring in younger women. And then we have medications that we use to treat conditions, most commonly being systemic steroids to treat these autoimmune conditions. But the good news is we now use many of these human antibody approaches to autoimmune and rheumatologic conditions, and even cancer treatments now that have less impact on bone health. But in over-the-counter medicine, I want to highlight anti-acid medicines to treat acid reflux, something we call GERD now. Anytime we reduce stomach acid, we impair digestion of calcium and vitamin D. We also impair iron digestion and vitamin B12 digestion. So these anti-acid medicines that are over the counter are not as benign as people think they are. And in fact, they have a warning label on them now about risk of fractures when used long term. Now, people with significant conditions sometimes have to take these medications, and it's a balance between the active condition being for which the medications are being used and balancing bone health. So there's no absolutes here. We've got to juggle in medicine. And as we age, we have multiple medical conditions that require a very thoughtful approach to managing multiple medical conditions with multiple medications. But we want to highlight that whenever possible, using these medications with the lowest dose and the shortest duration and trying to taper the dose and remove the medication and seeing the effects are very important ways of long-term management of health, and very important to have a primary medical provider, physician, nurse practitioner, physician assistant who knows all the medical conditions, all the medications, and is thinking about drugs and adverse effect on not only bone health, but all types of physiology, and making a treatment plan that's individualized to optimize health, including bone health. I want to highlight breast cancer and prostate cancer treatments, the hormonal treatments that are used and very effective in preventing recurrence of cancer for the breast, but also treating prostate cancer can be very harmful to bone. And very important as these cancers are being treated, that bone health is being managed with bone density for understanding the bone health, and then actively managing bone. And many of our oncologists are very comfortable managing the bone health of a cancer patient, but very important to be aware that while we're managing cancer, we also have to manage the bone health. Okay, let me move to the next slide. Let me see. There we go. I want to highlight the Bone Health and Osteoporosis Foundation as a wonderful resource. No longer, and I say no longer because when the National Osteoporosis Foundation first opened its doors, it was heavily funded by the pharmaceutical industry that made our first FDA-approved osteoporosis drugs. And so there was a big emphasis on using these drugs. That's not true anymore. And in fact, it is a very thoughtful and unbiased approach to bone health with a lot of good information on bone health behaviors and not just medications. So I want to highlight this website for a wonderful place to get education. So I'm going to start with healthy aging by nutrition. And my bottom line here is that nutrition doesn't come in a bottle. It doesn't come in supplements. It comes in food and beverages. And that's tough to do in our busy American society, where we can get lots of pills and not then have to worry about what we take in for our meals. But I can tell you that gerontologists and geriatric medicine medical providers at Johns Hopkins have a medicine cabinet that's very empty. It's got a little bit of acetaminophen for when we overexert, and if we overexert too much, a little bit of a non-steroidal anti-inflammatory, something like ibuprofen or naproxen. And it has one vitamin supplement, and only one, and that's vitamin D. And that's because we live in the mid-Atlantic region here at Johns Hopkins, and our sun exposure that allows vitamin D metabolism that begins in the skin. From October to May, the sun is in the mid-Atlantic region is not strong enough to do the metabolism for vitamin D. Now in the summer, 10 minutes a day of exposure, face and arm, is sufficient for vitamin D metabolism for most adults, but we are all health conscious in terms of skin cancer and aging on skin. And so we apply sunscreens or barriers. And without that sun exposure, or if we use sunscreens, we don't get the vitamin D metabolism. So our medicine cabinets in gerontology, we have ibuprofen, acetaminophen, and vitamin D. And how much vitamin D? Most adults need 1,000 units in the Mid-Atlantic region, but there are some who need more. Those who have GI malabsorption issues, those who take antacid medicines, people with celiac, people with Crohn's disease, some people will need as much as 5,000 units a day. But the average adult in the Mid-Atlantic region, 1,000 units is sufficient. And this is, I'd like to emphasize the term optimal for health. If a little bit is good, is more better? No, optimal. Excess vitamin D might predispose one to calcium deposits in blood vessels that can cause the atherosclerotic cardiovascular diseases of heart attack and stroke, and can increase calcium deposits in areas of inflammation, including our joints. So those with osteoarthritis, excess vitamin D might harm or might progress that condition. So more is not always better. Optimal is what we try to achieve. For calcium, optimal calcium intake is what I usually say 3 dairy servings per day, and not all 3 in one meal. A serving should be at least 2 hours apart for optimal digestion, but no more than 600 milligrams of calcium at a serving. So whether that's breakfast, lunch, or dinner, or snack, but 2 hours apart with the 600 to get to 1,000 milligrams. Now, people who take certain medicines, loop diuretics, things like furosemide, butacimide, people with heart failure, they're going to need a little more calcium, probably 1,200 milligrams. People who take thiazide diuretics for a little bit of leg edema, so hydrochlorothiazide, that diuretic actually changes how the kidney handles calcium and puts calcium from the urine back into the blood. And so those folks might get by with as little as 800 milligrams in their diet daily. So how do we get 1,000 milligrams? There's no perfect or optimal way. It's what you'll do every day in your diet. So there are half of our adults are lactose intolerant. So just drinking cow's milk will cause gas and bloating. For those who aren't intolerant, it's a great way for getting, and skim milk has the same amount of calcium without fat and cholesterol. But there are alternatives. Lactose-free milk and lactose-free dairy products such as cottage cheeses or cheeses are now readily available in grocery stores, but they are a little more expensive. Almond milk is a wonderful alternative. And then single-serving yogurts or puddings, tofu, and there are non-dairy sources of calcium, but they're all far less per serving. So yes, leafy greens have calcium, but a single serving is typically going to give you only about 100 milligrams. Now, I'm not going to sneeze at 100, it counts. But some people think, well, I have salad for lunch every day, and I have spinach or kale at dinner, and I don't have to worry about dairy intake. And usually that's not, it's tough to get sufficient calcium with greens alone. But that website I showed you earlier from the Bone Health and Nutrition has a calcium food table. Also, just doing an internet search of calcium content of, if you look at your typical diet, what you have every day, you'll see what calcium content are in the various foods that you like to eat, and you can calculate for yourself whether you're getting optimal calcium. But before you reach for that calcium bottle in the grocery store or the pharmacy, do your best to look at your diet, look at this food table, see how you might optimally achieve calcium without a single calcium pill. And I'll show you why that's important in a moment. What about other nutrients? Yes, there are other nutrients that impact bone physiology, bone metabolism. I'll highlight vitamin K. Vitamin K plays a role in what we call the cross-linking bone proteins and making them stronger. However, vitamin K also promotes blood clotting. And as we age, we are at risk for very significant life-altering blood clots of heart attacks and strokes, as well as blood clots in the veins of the leg that can cause break off and cause blood clots in the lung. So vitamin K supplementation is not something we recommend for older adults to improve their bone health, because the potential harm is far greater than the potential harm to their cardiovascular system is far greater than the potential benefit to bone health. But getting vitamin K through routine diet of fresh fruits, vegetables, lean meats, our cardiovascular, heart-healthy diet is that includes low-fat dairy products is what we say is good for bone health without any additional supplements other than vitamin D. Now, if we all move to Florida or the equator, we might not need that vitamin D, but I'm here at Johns Hopkins, so I'm going to take my vitamin D. Now, what about this issue of can you just treat osteoporosis with vitamin D and calcium supplements? And the answer is no. You need these supplements for normal bone physiology, but they don't have power to change thin bone into better bone. But without adequate calcium, you can harm bone. But there are randomized clinical trials looking at calcium supplements, and there are also very large observational studies that suggest that calcium supplements may increase the risk of heart attack and stroke, the number one killers of men and women in this country, not fractures. And so let's keep our hearts and our brains healthy and do our best for our bone health through nutrition. Okay, and I just want to highlight on this slide, Erin Mikos is a preventive cardiologist at Johns Hopkins, professor of cardiology. She's done fabulous research in women and osteoporosis who have cardiovascular disease, and again, trying to look at these common diseases of aging, cardiovascular disease, osteoporosis. How do we manage both of these conditions at the same time? And we're understanding more and more how to do this. How much physical activity to maintain both bone? Getting up every day, walking, weight bearing, physical activity, housekeeping, climbing the stairs. You don't need a treadmill to be bone healthy, but you need to get up and move around. And many of us at Hopkins now have our standing desks so that we aren't sitting all day long, even when we have to be in front of the computer. Now, if you want, weight bearing is very good for the upper spine and the arms, shoulders, but it needs to be done safely. And that's because we have degenerative changes with aging in the joints of our spine. And we can pinch nerves and cause significant weakness and pain and numbness of our hands, our feet, if we don't do weight bearing safely. So if we're going to start lifting weights, they should be limited in the amount, and we should stop the repetitions if we're fatigued. Ideally, if you want to do weight bearing, I recommend having a session with a trainer just to be sure your technique is safe in preventing pinched nerves. With a diagnosis of osteopenia or osteoporosis, insurances will pay for a physical therapy evaluation for an exercise program that is safe. So if one wants to start doing more for physical activity, to do it safely and prevent pinched nerves, slip discs of the spine, do so either with a trainer or with an exercise class in a senior center where there are trained exercise trainers to safely help you with weight bearing, or ask your medical provider for a referral for physical therapy with a diagnosis of osteoporosis, for a weight bearing exercise program, fall prevention program, posture and gait training. Those are the three areas physical therapists can be helpful with the diagnosis of osteopenia or osteoporosis. I want to show you the research on smoking and alcohol intake and bone health because they're significant. Fracture risk for smokers, for women, is significant, and for men. And alcohol intake of 3 or more drinks daily also increase, data show. So if there's one more reason to not smoke in the beginning or to stop smoking with aging, not just cardiovascular disease, not just cancer, it's fractures and alcohol intake in moderation. Okay, what about caffeine? I say 2 caffeinated beverages per day. What about phosphated sodas? Yes, that does cause a problem with calcium absorption. I prefer that people use waters and iced teas rather than sweet fruit juice or sodas. Those are our recommendations for healthy behaviors. All right, next slide. Let's go to now appropriate use of screening for osteopenia, osteoporosis. So when we first started having bone density, there was the Bone Mass Measurement Act of 1998, an act of Congress to get Medicare to start paying for this screening test. We now, and we were doing the screening test, usually as women were traversing the menopause. What we found over time was that women can afford to lose a little bit of bone with menopausal transition before they get into trouble with fractures. So we aren't starting osteoporosis, osteopenia medicines as early now as we did in the early 2000s. So the actual recommendation for the first screening bone density for all women in this country is age 65 years. If you're a healthy woman with no medical conditions, your first bone density should be age 65. But women have medical conditions that can increase their risk of osteoporosis before age 65. Those conditions that I listed as conditions that cause bone loss are all appropriate for a woman to have a bone density. And when men have these conditions, such as rheumatoid arthritis or Crohn's disease, they too should have a bone density bone density for the women before age 65. Exactly what age is a discussion with your provider for the severity of your condition, the medications being used to treat the condition. So I can't give you a global recommendation for what age to have a bone density if you're someone with Crohn's disease. But if you're someone who has no medical diagnoses and you're a woman, your first bone density should be age 65. And your insurance will pay for it with the diagnosis of being a postmenopausal woman in the age of 65. There is no screening for men. There's no specific age for men. But for men who have had a fracture is a warning that, in fact, there's a problem with the bone. And there's a judgment call. Some people say, well, it was a car accident. And there's actually a study, a longitudinal study of men and women who had bone densities over many years and behaviors were assessed, and whether or not they had a car accident. If they had a car accident, did they fracture in the car accident? And sure enough, more fractures in people with lower bone mass. So in fact, usually there's a fall or a traumatic injury, such as a car accident, is a stress test on the bone. And if you fracture, you failed the stress test. We do stress tests for coronary artery disease, but we don't have a medical stress test for fractures. But people do it on their own with traumas. And when there's a fracture, we think about, was this trauma sufficient that any normal bone would have fractured? Or is this a warning that that bone mass was low and this injury then caused fracture because there was low bone mass? Now, bone density. Bottom line, it's a lousy screening test, but it's all we have. So people put a lot of faith in this bone density, and I'm going to show you that we got to be a little cautious in how we interpret it. So I don't mean to sound negative, but there's some realistic issues here. The hip is a very accurate test, but the hip bone, the type of bone that's in the hip, changes more slowly with aging. The spine is where women lose with the menopausal transition, lose the most and the quickest. But there are some artifacts in the spine, because the spine is a series of joints, one spine bone up next to the other. These joints get degenerative changes with aging, and calcium deposits get put there. And so unfortunately, as we get older, sometimes our spine bone density keeps increasing, but the spine bone itself is not increasing in bone mass. These joints are. Well, how do we interpret a bone density? So here's the hip. We use something called T-scores. We report Z-score, but as we age, the Z-score is a comparison to age match. Well, half of women have osteoporosis at a certain age in our country. So it might be, well, the good news is you're like every other 80-year-old woman, but the bad news is you have osteoporosis. So in terms of diagnosing and managing osteoporosis in older adults, we do not look at Z-scores. The Z-scores are only useful in young adults, 30 and 40-year-olds, when we're managing them with the medical conditions associated that have caused their osteoporosis. So let's focus only on T-scores. Older bone density machines had a lot of numbers, but only two numbers predict fractures: the total hip and the femoral neck. And the femoral neck is this region that goes into the hip. Now you might say, what about arthritis of the hip? Arthritis of the hip is up here at the joint where the pelvis joins the hip bone. And that's not the area of scanning in bone density. It's this femoral neck area where the majority of fractures in older adults occur, or this trochanteric area. So total hip is all of this area. Femoral neck is just this area where fractures occur. And they're the two areas for diagnosis. Normal bone density, we use T-scores, which are standard deviations from normal peak bone mass. And a value that is more positive than a -1 is considered normal, bad news. Osteoporosis is more than 2.5 standard deviations from normal bone mass. That's the World Health Organization classification. Oops, I think I'm on a it's advancing before I want it to. Let me go back here to previous, just so we can get this, okay? So these T-scores are comparison to age match: femoral neck, total hip. Those are the two. So this patient's hip would be considered normal because the total hip and the femoral neck have a score more positive than -1. Okay. Wards is no longer reported in machines, although you might see an older report with wards. Everybody has a low area. It picks out the lowest area of the hip. It doesn't predict fractures, so that's why we don't report it anymore. Now let's go to this challenge. Here's a spine. What do you see in the scout film? You don't need to be a radiologist to see. Look at this lumbar 4 vertebral body. That's not normal architecture. That's a false reading because of calcium deposits in the joint that brings this lumbar 4 and lumbar 5 together. Totally worthless. And you can see T-scores are varying here with this patient from lumbar 1 to lumbar 4. And the bottom line here is this patient's bone density of the spine is not clinically meaningful. because of these degenerative changes. What do we need? We need a forearm bone density. Now, when a provider orders a screening bone density, they get only a spine and a hip. And that's because the code used for bone density, the standard code, only includes spine and hip, because that was older. When we first started having FDA approval for bone density, there were no forearm scans. The technology didn't exist. So when your doctor orders a bone density, they get only the spine and the hip. There is a second diagnostic test or a classification code to give a forearm bone density. You have to order it separately from the spine and the hip in order for a radiologist to do the hip scan or do the forearm scan. And this is just one of these, unfortunately, administrative challenges of the practice of medicine in this country. And so people, there's some people walking around, there's some people walking around who think they are just mild osteopenia, when in fact they have osteoporosis if a forearm scan had been done. So I educate a lot of primary care providers on this nuance with aging. If somebody has deformity of the spine, height loss, because it's not that the bone is lost, it's that the discs between the bones of the spine have been lost, degenerative changes that may give a false reading of the spine. So you need two orders. You need the bone density of the spine and hip, and then a second order for the forearm. And we do the non-dominant unless there's been a fracture. If you've had a fracture of the forearm, there can be, as that fracture heals, there can be extra, we call it callus, extra deposits of calcium in bone that will give an impression that the bone's higher density than it really is. So non-dominant can be lower than the dominant arm. So we do a non-dominant forearm. And I wish if I were in charge of Medicare, I would change this nuance and make sure that everybody gets a forearm, a non-dominant forearm with a hip and a spine. Okay. Now, also changes in bone density. The machines all have they're different softwares that calculate area of bone, and so they give an absolute difference in bone mineral density for the same individual, just because their software is different. So when you're looking over time, doing multiple scans over time, particularly when there's a treatment plan and FDA-approved medication being used, you must go back to the same machine and let that old machine call up the old data with the new data and calculate rate of change. There's also significant variability, 3 to 6%. And the average change with aging is 0.5 to 1%. Bottom line is there's no reason to do a bone density more frequently than every 2 years, with very few exceptions. And as a result, insurances only pay every 2 years because that is the medically appropriate time for serial management. Sorry, back here. So people say, but I want to know. And say, but you only want to know when it's appropriate information. Bone density gives us a macroscopic assessment of bone mass, but changes over time in the architecture of bone are microscopic first. So if you took a piece of bone, looked at it under the microscope before and 2 years after starting an FDA-approved medicine, you would see significant differences under the microscope that give bone increased strength. But you won't see a difference in the bone density. It should be stable. Now, I mentioned that you might see an increase in the spine, and if you do, it's that issue of aging and degenerative changes of the joints of the spine, not that the bone is more dense by bone density technology. Now, if you see serial loss in the bone density, we stand up and take that seriously. Why is this person not responding? Why haven't they stabilized and no longer have age-related bone loss? And then we look at things of calcium absorption, vitamin D absorption when we're using oral medications. Is there GI malabsorption of those oral medications? Is there something else going on medically, a condition that's not adequately treated, like uncontrolled type 2 diabetes causes bone loss? But we don't expect bone density to get better with our routine medications. Now, medications, there are a few medications that build bone, daily injectable hormones of teriparatide and teriparatide, and the newest medication, romosozumab, do increase bone. And there we expect to see some improvement in bone density after 2 years. But for our routine medicines that stop age-related bone loss and result in a 60% decrease in fractures, we don't expect the bone density to get better. We expect it to be stabilized. Now, that's not very comforting. That's like my saying to you, you have high blood pressure. I'm giving you a medicine to treat that high blood pressure. By the way, your blood pressure is not going to go down, but will reduce your risk of heart attack and stroke. That wouldn't sit well with me, and I understand that because you expect a cause and effect with your treatments when we have a screening test. Bone density is not sensitive enough to pick up the changes in the microscopic architecture of bone when we use our standard FDA-approved medicines, and that is a reality. So I get a lot of patients referred to me because their bone density didn't get better when they were treated with daily or weekly oral bisphosphonate. I'd say, you're normal. I'm sorry, that's not very satisfying, but in fact, it is what we expect. However, when someone's referred to me because they've lost bone density, I take that seriously and evaluate if there's a medical reason that I can identify. But I will also tell you that I have to first look at the bone density, look at the images of the prior one and the newer one, look at the positioning of the bone. Technically, there can be technical issues, and I have had to send patients back for a repeat scan with a different positioning of the hip before I could say that that medicine isn't working. So there's some nuances in interpreting bone density that make it a little more challenging than, say, here's a result on a blood test. Now, what do I do with that result? So, but these are the challenges we face in bone health. But I'm not a pessimist. We still do screening. The screening test is very effective. Well, if you have a screening test, what do you do with the results? If you have normal bone density, you don't need another bone density for at least 5 years, and you may not ever need one. But if you're within the osteopenia range, and I don't have time to go through these data in more detail, other than to say, if you're osteopenia or osteoporosis, I recommend repeating 2 years. Now let's get to the medicines. And there are two classes. Ones that stop bone loss, we call them anti-resorptive. So those cells that degrade bone, stopping those. And I'm not asking you to understand all the different physiology here. I just want you to know that we're beginning to understand it more and more with our medications. So we're getting more effective medications. So we've got 3 classes of medicines that stop bone loss. The most common, the bisphosphonates, the pills that have been around, FDA approved since 1996, October of 1996. I remember well, because for many years of my clinical practice, I didn't have an FDA-approved medicine to treat the patients who came to me with osteoporosis. So the bisphosphonates are dosed weekly or monthly as pills. They're challenged because their GI absorption is a challenge. So they must be taken on an empty stomach first thing in the morning, only with water. For the weekly dosing, waiting 30 minutes before eating or drinking or taking anything but water. The monthly dosing we do with an hour wait. But they reduce fractures by 60% for the majority of patients. And I'll show you a slide with our most recent clinical guidelines. This is where we start for the average individual with osteoporosis, whose screening bone density done for the appropriate reasons have that T-score of negative 2.5. Or they have osteopenia with an additional adding their clinical risk factors in a calculation that's done during the bone density, and their 10-year fracture risks are for major osteoporotic fractures exceed 20%, or hip fracture risk exceeds 3%. We recommend FDA-approved medications, and we start with the oral bisphosphonates. Now, they're individual. About 1 in 10 individuals will not tolerate oral bisphosphonates because of GI acid reflux symptoms. And then we use the non-oral. We have an intravenous bisphosphonate called zoledronic acid that's dosed once yearly for 3 to 5 years. And then we have a monoclonal human antibody called denosumab that is given by subcutaneous injection in the arm every 6 months. Now we have one other medication, a pill called raloxifene, which is estrogen-like on bone, but not estrogen-like in the breast or the uterus. This medication over time has been shown to be less effective for fracture reduction than the bisphosphonates or denosumab. And so it's not our go-to medicine, but there are some individuals, women who have a family history of breast cancer and have osteopenia, but not osteoporosis. This might be a good medicine because it has been shown to reduce the risk of breast cancer in women who are at risk for breast cancer, as it also prevents bone loss. But it's not the majority of women where we start. Notice I don't have estrogen up there. And that's because the long-term risks of estrogen outweigh the benefits for the majority of individual women in terms of cardiovascular risk and in terms of breast cancer risk. So that's why we don't have estrogen there. Now, there are some women, I saw one yesterday in my office, who has very low cardiovascular risks, significant menopausal symptoms of hot flushes and sleep disorder, and she's on estrogen for her osteopenia, as well as her menopausal symptoms. So, for every rule, there's an exception. Each person is an individual, and you want a treatment plan considering all the health needs. But for the average person with osteoporosis, the go-to medicines are oral bisphosphonates as first line. Now, people who have failed medications, and we consider fracture after 2 years on these medications to be, you need 2 years of medication before we say that we've failed the treatment. We then go to agents that build bone. Teriparatide and valoparatide require daily injections of a pen. Romosozumab, and these are limited to 2 years because that's the clinical trials for FDA approval. Romosozumab is an injection in the arm, actually requires 2 syringes once a month for 12 months. Our newest FDA-approved medication, out about 4 years now. And it builds bone. The challenge with it is only FDA-approved for women with a warning label about risk of heart attack and stroke. Unfortunately, this medication has an overlap with atherosclerotic plaque formation. And heart attacks and stroke are the #1 killer of men and women in this country. And so we're very thoughtful about the use of romosozumab because of the potential for cardiovascular. And it's interesting. Many years ago, I had a patient say to me, my bones are thin with less calcium, and now you're telling me there's calcium deposits in my blood vessels that are causing angina, risk for stroke. And that it's interesting aging physiology here that we're trying to understand more so that we can get effective osteoporosis medications and not harm the blood vessels and atherosclerotic plaque formation. And we've got a ways to go yet before we've accomplished this task. These are the guidelines from the American College of Physicians for osteoporosis treatment. And the bottom line here is recommendation 1 is the use of the oral bisphosphonate. So what is old is new. So yes, we have fancier drugs with subcutaneous injections and daily injections through pens and the monthly romosozumab, but that's not where we start for the majority of individuals. And I just want to show you these guidelines. So for postmenopausal women, the intervention, the bisphosphonates are where we start. Now, bisphosphonates accumulate in the bone. So after about 5 to 10 years, and I know that's a broad window if you're an individual person, 5 years or 10 years, For the majority of women with newly diagnosed osteoporosis, I treat for about 5 years, and then we do a pause of 2 years because the medication accumulates in the bone and continues to work. And in fact, as it accumulates, it can begin to slow new bone being made. So while it stops age-related loss, it can have a negative impact in building new bone. And so we do a drug holiday. And we use the term holiday because holidays are always good things. We enjoy them, but they come to an end and then we go back to our daily routine. And so for the medication, we do drug holidays, usually after about 5 years. And we do drug holidays for about 2 years, following bone density every 2 years. There is a blood test we have begun to follow. It is the breakdown of bone protein specific to bone that guides us a little bit in the use of these drug holidays. Okay. So to summarize my talk for today, I hope I've shown you the behaviors of healthy aging: nutrition, physical activity, not smoking, limited alcohol use. I hope I've showed you that there are conditions, medical diagnoses that impact your bone health, or medicines that impact bone health. I hope I've impressed with you that we have a screening test. All women age 65 in this country should have a bone density as routine health. Younger women in the menopausal time frame based on their medical conditions. Men, regardless of age, based on their medical conditions. I hope I've shown you that we have a thoughtful approach to medication use and appropriate use of bone health nutrition. And I'll stop there and I've left some time for questions.
Thank you so much, Dr. Bellantoni. That was a wonderful presentation. Our first question, my osteopenia seems to have improved in the last 6 years. I think it's because of related to weight-bearing exercises and more calcium and vitamin D. But the question, does K2 make a difference?
So I answered that question. And my answer is not, will it make a difference for my bone? The issue is, I am aging. My cardiovascular diseases, or my cardiovascular system is aging, and my bones are aging. Should I supplement with vitamin K and risk cardiovascular disease because I have osteopenia? My answer to you is no. So would it make a difference on your bone? Probably. But is it a significant enough risk to your successful aging? My biggest concern. So in gerontology and geriatric medicine, we think about the whole person, all their health conditions, all the age-related conditions, and we sometimes have to compromise all of our recommendations for one condition so we have total health optimized. So that's how I answer that question.
Yeah, thank you. If I have osteopenia and have scoliosis, do I need more frequent bone monitoring?
More frequent bone monitoring is always no, because the test is not useful. So while you're at risk, so scoliosis is, I didn't have time to talk about this in much detail, but scoliosis is a genetic issue. There are certain proteins that I don't want to call it a disease, but they're variants, and they often lead to more malleable bone. And so during the teenage years and young adult years, people can often be very athletic and be very flexible. But with aging comes this curvature in the spine because of these changes or these difference in proteins. And peak bone mass is usually less, so you can't afford to lose as much. But more frequent monitoring isn't useful because the test isn't good enough. Just to share with you a little story, we have biomedical engineering master students at Johns Hopkins, and they're always looking for a thesis, what they might do for their research that would be meaningful to health and aging. And they actually spend an afternoon with me in my outpatient practice because I am trying to get them interested in developing a new technology that will be more sensitive for us to be monitoring bone health. I tell my cardiologists, it's like they're managing coronary artery disease and all they have is a 12-lead EKG. They don't have a calcium CT score. They don't have angiography. They just manage with a 12-week each kg, which is how we managed when I was a resident of Johns Hopkins Hospital many years ago. Their technologies have advanced in screening and diagnosis. Mine have not. And Dan, we need to do better. So hopefully we will.
Yeah, thank you. Do people that ingest, I know you touched on kind of the foods to eat, and if you're lactose intolerant, but have you seen that people that ingest a lot of animal protein have more bone loss than people on largely vegetarian diets?
Yeah. There's some health benefits of vegetarian diets and there's some risks. A reasonable cardiovascularly fit diet is going to help your bone with the addition of dairy or lactose-free dairy. So I have to use that term. Homework assignment, go to the grocery store. It's amazing how grocery stores have changed. And I actually send my medical students who rotate with me, their homework assignment one night is to go to the grocery store and come back with a list of how you will get your calcium without having milk. And part of it is so I get updated on what's new. But also it's amazing how, as we understand health, there are many non-dairy forms of, or lactose-free forms of ways to get calcium. There is no one way. Interesting, total cereal. When we first started understanding osteoporosis, they put 500 milligrams in a routine serving of total cereal, calcium, and they advertised it as bone health for women. Then the studies started coming out about calcium supplements and heart attacks. They took the calcium out of total cereal because of those studies. Totally unrelated information, but the worry was people would stop taking the total, or people who were taking total cereal would stop eating it because there was calcium in it. So there's something about food and beverages and how they're digested that are different than pills of calcium. That's all I can tell you. We don't understand more, but we do understand from good research that it makes a difference, long-term health. And we're not talking about the first 2 years of a diagnosis of osteoporosis. We're talking about lifelong behaviors. So a woman at age 65 in this country is expected to live into her late 80s right now. And she's going to fracture, not at age 66. She's going to be in my emergency room when she's 78, 80, 82. And my goal today is for her not to be in my emergency room at that age because she started healthy behaviors at age 65 or before age 65.
Absolutely. Thank you so much. Looks like we, do you have time for one more question?
Sure.
Okay, it'll be a follow-up to the last question. On the dietary, consuming calcium, if the lactose milk or the lactose intolerant options cause gas and other digestive effects, does that mean that the calcium in dairy products is not being absorbed?
I can't answer that with research. I think that I'm going to say, if you're uncomfortable, you're not going to do it long term. So it doesn't really matter. If you're having symptoms, don't do that. Find another way. Hard cheeses like Parmesan cheese. It's amazing to me that people who are lactose intolerant can often tolerate that. So Parmesan isn't something you just put a little bit on your spaghetti. Try little bits of it as a little snack and see if in fact you can tolerate it. But again, almond milk, lactose-free milk, lactose-free cottage cheese. And again, there are foods, tofu, almonds, kale. You can do it without dairy, but it takes effort. And I don't have the time to go through that in a lecture like this. But I've given you the resource of the Bone Health and Osteoporosis Foundation website to give you the tools to do it yourself, or to request a nutritionist consultation from your primary care to address your calcium in your diet. There's a question there about atrial fibrillation and alendronate. I want to say as a geriatrician, atrial fibrillation is a very common condition in older adults, and it needs to be managed, but so does bone health. If the atrial fibrillation is appropriately managed, we can use our medications Our medications for osteoporosis can transiently lower calcium level, which could worsen atrial fibrillation. That's why you've got to have adequate calcium intake, adequate vitamin D intake, and manage your atrial fibrillation. But I routinely manage osteoporosis effectively with our medications in people with atrial fibrillation. Okay. And that's the challenge as we get older. We got more than one health condition, but we're up for that challenge. Okay.
Great. Well, thank you so much, Dr. Bellantoni, for your time today and your expertise. It's been wonderful, and thank you all for joining us here online today. And I hope you have a great rest of your day. The recording will be sent out this afternoon.
Great. Enjoy your Parmesan.
Thanks.
Bye.